session. And as all of you know, diabetes is no more a disease of sugar, it is a disease of complication. So we have kidney, we have liver, we have metabolic problems, so and cardiac issues. So we have the first speaker. CV कहाँ चाहिए? Our first speaker is Dr. Shehla Shaikh from Mumbai. She is a consultant endocrinologist at Safi Hospital and HN Reliance Hospital, Mumbai. She was the principal investigator in International Clinical Trials 35. She is a member of Executive Committee ESI 2021 to 2024. She is a treasurer ESI Maharashtra, awarded Top Docs Mumbai by TOI Group, received Hamdan bin Rashid Al Maktoum Foundation for Medical and Education Science Award for research in Ramadan, author of International Huz and Diabetes Guidelines and IDF DAR Guidelines 2021. She has published many papers, review articles, and speaker and national and international forum. Welcome, Dr.
Thank you. Thank you for those kind words, sir. Thank you very much. And it's an absolute pleasure being over here. Thanks to the organizers for having me over here. I have one of the organizers, Manoj, over here. So I can personally say thank you also. And, you really wonder, why CKM? Why are we talking about, don't we know it all? Why are we talking about something which, we've been doing this from years. We've been talking about the metabolic syndrome. We know about obesity. We know about the fact that obesity is now a harbinger. It is the metabolic syndrome is a harbinger of diabetes, hypertension, dyslipidemia, and finally this is going to result in cardiovascular complications. So what's new? What am I going to talk about in the next few minutes assigned to me to keep everybody awake? We at this point of time are in very exciting times as far as medicine goes. The reason I'm saying exciting times as far as medicine goes is because we have newer molecules. We have a huge amount of data now available. And we now know, sir very rightly said, when sir started sir started talking, he said we have moved from that era where we talk in terms of glucose to an era where we are now talking in terms of complications, where complications actually are deciding your therapy. And when it is complications which are going to be deciding your therapy, and when you have so much more new data which tells you which direction to go in, it makes sense to sort of connect these dots, put these. Bansi, I said thank you to you first only at the beginning. It makes sense to connect all these dots together and create a kind of situation where it's easier for you to sort of identify where you want to go, where your starting point is, which direction you want to go in. And that is what I'm going to be talking about in trying to turn the tide with GLP-1 receptor agonists. These are my financial disclosures out here. So when you talk about CKM syndrome, what are you talking about? Mind you, it has been labeled as a systemic disease. Okay, it's a systemic disease which is finally going to result in cardiovascular complications. Fair enough. But if you look at this, what you would realize is, I'm not going to get into these numbers, you realize it is this innocuous adipose cell. Conventionally, as students, we never paid much attention to the adipose tissue. It was just adipose tissue, it's a fat cell. We are now better as far as knowledge goes. We now understand that when we are talking about adipose tissue, when you're talking about ectopic adipose tissue, especially when you're talking about the entire ectopic fat hypothesis, where fat is deposited in the liver, fat is going to be deposited in the epicardial tissue, it is going to be deposited in your blood vessels, and it is the harbinger of a number of metabolic complications. And when I say metabolic complications, I mean the works, because it is causing inflammation, it is causing your oxidative stress, your resistance, your vascular dysfunction, it is affecting your kidneys, it is resulting in glomerulosclerosis, tubulointerstitial disease, glomerular disease. At the other end of the spectrum, it is associated with your MAFLD, it is also associated with hypertension, dyslipidemia, and to add to this entire story, finally you're going to have a situation of ASCVD, cardiac remodeling, fibrosis, and is going to result in an increased incidence of cardiovascular mortality. So the story starts, friends, with that innocuous adipose cell, right? Something so innocuous. That is what is causing all this that we are looking at this point of time. And that is where this CKM comes in picture. The reason CKM comes in picture is because we are now emphasizing, think about the 8 factors which make a difference as far as primordial prevention is concerned. When you talk about primordial prevention, we are talking about the 8 factors, and these 8 factors are something which we all are aware of. But when you put it that way, it makes much more sense to sort of know, okay, this is what I'm supposed to look at as far as my patients are concerned when I want to actually plan prevention. Most of us sitting in this audience, and I would include myself in all this, is that we really do not think too much in terms of primary prevention. Yes, we talk about sleep, we talk about idle body weight, we increasingly talk about good blood pressure control, good glycemic control, we will talk about good sleep hygiene, we talk about this. But in a busy consulting, which you and me are in, where we can really make a difference is over here, stage 2. And I think with actually now, since we absolutely know what the CKM is all about, and since now we have medication which can make a difference, it's almost not right to not do something at this stage when you actually can. When this is the beginning, when you're stage 1, where you have your overweight, abdominal obesity developing. The latest definition of clinical obesity, latest paper of Lancet last month says, obesity is now going to be defined as preclinical obesity, where obesity is associated with no complications, and clinical obesity, where obesity is actually associated with complications. So we are now just defining obesity by itself without any comorbidities also. We are also increasingly, though we talk about metabolically normal obesity, we all know that even in a patient who is metabolically normal, but if the patient is obese, that patient is a sitting duck, is at a risk factor for cardiovascular disorders, and this patient needs to be on therapy much earlier on, needs proactive therapy as far as obesity is concerned, and that's where you and me need to make a difference. Unless you and me are able to make a difference at that point of time, believe me, we'll have missed the boat somewhere. Where we come in generally is at stage 2. Where you and me actually come in is at stage 2. Because we're supposed to medicos. Patients think they come to us when they're unwell. Patients don't come to you and me for primordial prevention. They'll most probably go to the gym instructor, or they'll go to the friendly neighborhood XYZ, but they don't tend to come to us. But we need to proactively make a difference over there. They come to us when they are in stage 2, where you already have metabolic risk factors that you all know about, which I won't go into in the interest of time. Stage 3 is just subclinical CVD and CKM, which you have subclinical ASCVD, subclinical heart failure. And finally, stage 4, which everybody in this audience is very, very well aware of, and resulting in all the complications, be it cardiovascular, be it stroke, be it your PAD, heart failure, etc., etc. So what can make a difference? Something as simple as losing weight is going to make a difference across the board. Over here is the most important message that we are trying to give. So along with management of all the other risk factors, is there something else we can at this point of time offer our patients as far as pharmacotherapy goes? Yes, friends, we can. We are, as I said, fortunate enough to be able to offer something to our friends as far as pharmacotherapy goes, and that's where GLP-1 receptor agonists come in play. We all know it influences appetite. We all know that GLP-1 receptor agonists are going to act through the hypothalamus. They're going to act on the arcuate nucleus, and that is going to stimulate your POMC and your CRT, which is going to reduce your hunger, your energy intake, and of course your food cravings. The most important history that my patients frankly give me when they come back to me when they're on GLP-1 receptor agonists is that it does reduce their food cravings, and that's what makes the difference to them. That's been my clinical observation with patients, other than reduced appetite, and it alters their food preferences. The alteration of food preferences results in them opting for diet which is much more healthier than what they would otherwise consume. And all this again is going to give you that huge amount of benefit, be it your liver, which you are really worried about. We have increasing data regarding NAFLD, MFLD. Though we do not have GLP-1 receptors on the liver, we know that indirectly your liver is influenced to a great extent by GLP-1 receptor agonists. Whether you look at your kidney, you look at your blood pressure, you look at the plaque or the myocardium, this indirectly through all these improvements that it causes as far as appetite is concerned, lipid profiles are concerned, indirect effects are concerned, whether be it your cardiovascular system, where it is going to reduce your inflammation, reduce lipid accumulation, reduce your vascular smooth muscle activation, which is finally going to result in a reduction in blood pressure, A1C, and also weight along with that. Yes, again, this is a meta-analysis, a very, very interesting meta-analysis, which shows that when you look at all GLP-1 receptor agonists, you do have a almost 13% reduction as far as cardiovascular death goes, 17% as far as fatal or non-fatal stroke goes, and 10% as well as fatal or non-fatal MI goes, and a 14% 3P MACE reduction. So you have a significant data out there which shows that be it the heart, be it the kidney, be it any kind of metabolic issue, you are going to see benefit. And that's where you are connecting the dots of CKM, because in the CKM syndrome, be it your heart, be it your kidney, because you all know this is interconnected. If you remember, when you go back to your undergrad days, we all read about the cardiorenal syndrome. We all read about the hepatorenal syndrome. And we all know finally all this is interconnected. And now you actually have evidence that yes, you can make a difference as far as the liver is concerned with steatosis, inflammation, NASH, and also last but not the least, fibrosis. So if you look at the inflammation, which is supposed to be the key factor as far as pathogenesis is concerned, you would realize that it definitely influences the NK alpha B and the P13K alternate system, which again is going to result in improvement as far as inflammation is concerned. I won't get into repeating this slide, but this is what we are trying to reiterate. So what is the current position? Where do we stand? What do the guidelines tell us? The guidelines tell us something very, very interesting. The reason I'm saying interesting is, because the guidelines have become much more, I would say, holistic. And the reason I would say holistic is because what the guidelines tell you is, yes, definitely think in terms of good glucose control. There's no questioning that. We would never move away from that. But also think about weight. Think about where your patient's weight is. They also say that very, very importantly, also think about the other cardiovascular parameters which matter. And all this finally, friends, is going to translate into what we want with good, efficacious drugs, which we at this point of time have with us. And that's the reason, if you look at the guidelines, this is what you have. Very, very categorical and clear guidelines. But I always reiterate that individualize. Your guidelines give you guidance, and then you would individualize it from your patient's viewpoint, what suits your patient best. And when you look at these guidelines, you would realize that when you look at these are your 2025 ADA guidelines, when you look at patients with ASCVD or high risk of ASCVD, what do you have? You definitely have GLP-1 receptor agonists over there high up on the chart with, mind you, a very, very small fine print. Proven cardiovascular benefit. Also, you would have, as far as CKD is concerned, again, if they are on a maximal tolerant dose of ACE inhibitors, again, GLP-1 receptor agonists, mind you, with proven CKD benefit. So you need to look at the evidence. We are in an era where we have evidence, and when you have evidence, you cannot afford to treat without keeping that evidence in mind. To add to that, this is again when you look at it, when you look at weight loss, I already told you we're talking about glucose, we're talking about weight loss, we're talking complications, we're talking about side effects. Efficacy as far as glucose lowering goes, very high with semaglutide. Also further, if you look at MASH, you want to mitigate the risk of MASLD or MASH, what do you have? You have GLP-1 receptor agonists, you have dual GIP agonists, and not to forget our very old and good friend pioglitazone. You can again take individual decisions as to how best you would use this in combinations. So the writing is up there on the wall. It's a question of how we are going to adapt it to make a difference as far as our population is concerned. We are going to understand as clinicians how better we can individualize it so that we can make a difference right from, I wouldn't want to say CKM stage 1, I would love to say CH0, but as of now, as far as pharmacotherapy is concerned, we would definitely talk in terms of stage 1 because you can now do something at stage 1. Lifestyle is and always is going to stay the cornerstone of therapy. There is no questioning that. Any one of us, when we talk up here about pharmacological therapy, never undermine the importance of lifestyle. That stays, and this is what uniformly the guidelines across the world say. And if I can summarize, there is a close association between CKM. We all know that. We have only now started connecting the dots. We've given it a name. We've given it a name so that we can understand it better. We can understand which direction we are going in better. It reflects a progressive process. Medicine is always a fluid branch. Medicine, the patient's prognosis, the patient's medical issues change, if not very frequently. In a chronic disease, they do change from consultation to consultation. And these are disorders which are going to finally result in increased cardiovascular morbidity and mortality. Improve glycemic control, improves the protection in addition to reduction in metabolic risk factors. This is what your GLP-1 receptor agonists are doing. And we have now moved from a glucocentric approach. I think we moved long time back. We are just reiterating, we are understanding better where we are. We are trying to understand which direction to go in. And I'm glad we have a roadmap in place. Unless you have a roadmap in place, you really don't know which direction to go in. You somehow tend to get lost because you looked after one part of the spectrum, but maybe you missed out on some other part of the spectrum because you just didn't have everything in place. And that's just exactly what I want to say. Thank you very much for your patient listening.